Good afternoon. Welcome back, committee members. Today is still January 25th, 2024, and we have a couple of bill hearings today. Just to let everyone know, the following bills are going to be rescheduled because their sponsor is ill, and it's my understanding all of the witnesses and everyone has been notified, but that is House Bill 142, 164, 192, 202, and 220. So we will reschedule those for a different date. So your afternoon just got a little bit shorter in this committee. We will start with House Bill 14 and call up Mr. Jared Demarinis, our State Board of Elections Director. Welcome back.
Thank you, Madam Chair. Thank you. And thank you for accommodating me being called first for my board meeting. So I appreciate that. Thank you. So House Bill 14 is a departmental bill. It does three changes in the election law article. One, it changes the reporting criteria for reports issued by the clerk of the circuit court and district courts to the State Board of Elections. It allows for the use of public buildings for an early voting center by local election board. And finally, it permits chairs of central committees to seek election to that central committee without necessarily resigning that office as being a candidate. So the first one I just want to talk about is about the report we currently receive from the Administrative Office of the Courts. Right now, we get a report that basically has everyone who's been convicted of a felony, and that is over-inclusive. And so this report would then help disenfranchise individuals if we had processed it completely, because the General Assembly had changed the law so that it's not just being convicted of a felony, but you have to be while currently serving, serving imprisonment for that conviction. And that change was occurred in 2016. So this basically mirrors the same language as what is the voter registration standards, and doesn't make it so that we receive a report that would disenfranchise potential voters. The use of public buildings is mandated for election day for polling places. So this brings in line the same provision for early voting, and it allows election directors the ability to seek use of these public buildings free of charge for early voting. So this would help us in our ability to get more facilities for us. So this is an important little, I would say, helping us expand our locations with early voting and making sure that they have all the necessary ADA and parking requirements and accessibility issues. Also, this has full support of the local boards of elections as well. And the last part here, which was just in the past, there was a term that says a treasurer. We're just changing the term from treasurer to a responsible officer, so it's more inclusive, to allow central committee chairs to seek re-election for that position. Because currently, if you're a candidate, you cannot have or exercise any general overall responsibility for another political committee, and a chair of a central committee does exercise general overall responsibility of that central committee. But, this is kind of like a small technical change here that, we have been monitoring overall, but I just wanted to make sure and just clean up the law. It's just so it's, it's just 100% compliant. So with that, I submit my testimony and look forward to a favorable passage. Thank you.
Thank you. Any questions from the committee? Delegate Henson.
And thank you for your testimony. Looking at the testimony that's been submitted by members of the public, there's something there from the clerks of court. And they indicate that the information on who's actively incarcerated may be difficult for them to obtain. If there was another party like Department of Corrections or some other responsible entity that had that, would you all be opposed to an amendment that included those departments?
I would not be opposed to any amendments. I just want to make sure that the lists are accurate and correct. Right now, I don't want to disenfranchise anybody that should not be disenfranchised, and that the current list that we receive from them would do that. So whatever the disqualifying event for an individual is once they go into imprisonment. So if the courts can just give us that, which is who's been sentenced to imprisonment and is was actually sentence and, going there, then we would have a more accurate list than just the felony currently.
Absolutely, and thank you for seeking to strike that as narrow as possible to preserve rights of other people who might otherwise be swept up in that. Thank you. Thank you, Madam Chair.
Any other questions from the committee? Okay, we have one individual who is here to testify unfavorably virtually, Dawn Lindsay. And Ms. Lindsay, hello, you'll have 2 minutes whenever you're ready. Oh, you're on mute. Can we? Yeah.
Thank you, Chairwoman Atterbury, Vice Chair Wilkins, and members of the committee for this opportunity to testify on House Bill 14. For the record, my name is Dawn Lindsay, Clerk of the Circuit Court for Allegheny County, Maryland. I am representing the 24 elected clerks for the Circuit Court for the state of Maryland. The clerks of the Circuit Court have reviewed the bill and would like to offer the following. While we understand the intention of the proposed amendment, we must oppose line 8 and 9 that require the clerk to report on who is currently serving a court-ordered sentence of imprisonment. This bill would require the clerks to provide information we simply do not have. Currently, we report to the State Board of Elections names of individuals convicted of a felony, but we do not receive updates from detention centers of individuals currently serving a sentence. Therefore, we oppose the amendments because we do not have the information the proposed amendments to this bill are asking the clerks to provide. We ask that they give House Bill 14 an unfavorable response. Thank you for the opportunity to comment, and I'm available if you have any questions.
Thank you. Any questions for Ms. Lindsay? Okay, seeing none. Thank you very, oh, I'm sorry. No, there is a question. Sorry. Delegate Fair.
Thank you, Madam Chair. And just to clarify, the current statute already requires the administrative clerk of each district court to report the names and addresses of the individuals convicted in a respective court of a felony. And it just adds another section to it. So can you help me understand, is it that you can't do the second part of it, the new addition, or you've never been able to do the initial portion of the statute to start with?
No, we do the initial part, and I'm reporting for the clerks of circuit court. And I believe the district court procedure is the same way. We report the initial sentencing of a felony. We don't get updates on when people are released, which they may get released. During COVID, people were released because they wanted to get people out of there. They may not have enough beds. Maybe it's good behavior. So we just do the initial reporting. We cannot provide any information on who is still serving, and we don't know where they're serving. So it's just that initial reporting that we can do, but we can't do the amendment that's asking for like current people serving. We'd have no way of knowing that.
Any further questions? Okay, seeing none, thank you very much. That concludes the testimony on House Bill 14. Mr. Demarinis, House Bill 112.
Thank you. So this is this is a joint departmental bill with the Secretary of State's office as well. But for me, this one here, this bill consolidates the reporting requirements for persons doing public business into one electronic filing database. Right now, there's reporting requirements at the Secretary of State's office, as well as with the State Board of Elections. It alters the time period of when the initial report is to be filed for the person's doing public business. And by the way, persons doing public business, let me back up a little bit here. This is under Title 14 of the election law article. It means anybody who has a contract, a business entity that has a contract of $200,000 or more with a government entity is a person doing public business, and that they have to file a semi-annual contribution disclosure statement with the State Board of Elections. So, and it's due in May and in November of every year. So this one now, they have to file an initial statement at the time when they receive the contract. This allows them 15 days in order to file that initial statement, and it gives a time period there. Additionally, for more compliance aspects here, it requires that person, because this is a $200,000 or more contract, requires that person to certify to the Board of Public Works, which is their threshold, that they are in compliance with the disclosure requirements of Title 14, which is that they have to then list all their contributors all their contributions that they've made to candidates. And finally, it also increases the enforcement authority for the State Board of Elections for late filing and missing information in this field here. So the consolidation is that the State Secretary of State gets their owners, the beneficial owners of these businesses, while we just get all the contributions. So now for moving their information into my database, the public will get greater disclosure and understand who is actually behind these contributions and who's winning these contracts of $200,000 or more. So this is once again a good government bill for ease, and it has enough teeth for compliance purposes as well. So I look forward to a favorable ruling. Thank you.
Michael Laurie for the record, Deputy Secretary of State. Jerry had explained the bill better than I could because he wrote the bill, but it was our request that they take on this responsibility because we have a very antiquated IT system. It's actually manual entry. They send the form even if they fill it out digitally. So instead of us procuring a new IT system, it made sense to attach it to an existing service that they provide for the voters to understand the contributions from people that do business with the state. This is actually consistent with what Boyd Rutherford, the former Lieutenant Governor, was doing with his procurement reform. They brought the two thresholds more into conformity, but this brings them into conformity because our threshold is 200,000 in the aggregate. Their threshold is a single contract of 200,000. This just makes a lot of sense. And to be frank, some of the paperwork doesn't get to them as soon as it should be because we have to manually input it. This way, it'll be much more streamlined and efficient for the state and the users.
Okay, thank you. Any questions from the committee? Okay, seeing none, thank you very much. That concludes the testimony on House Bill 112. House Bill 12, Delegate Ruth.
Sorry, oh, there we go. Good afternoon, Madam Chair, members of the committee. My name is Delegate Sheila Ruth, and I'm here for House Bill 12. When gas stations close, it can be difficult and expensive to convert the property to any other land use because of the underground storage tanks and the environmental remediation that's needed. This can result in former gas station property being left vacant, sometimes for many years, creating blight that negatively impacts community and property values. And as we expand electric vehicles, the market for gasoline is going to be lower and eventually be able to support fewer gas stations. So we risk having abandoned gas stations all over the state. HB 12 is enabling legislation that authorizes local jurisdictions to enact a property tax credit to convert gas stations to other land uses. The bill explicitly states that dollar stores and self-storage facilities are not eligible for the tax credit. We want to make sure that we're converting these properties into uses that the communities really want and that will benefit the communities. This tax credit will help pay for the cost of remediation to really encourage people to convert these properties into something that will benefit the community. The property gives the bill gives local jurisdictions the flexibility to define the amount, duration, and eligibility criteria, and the state will reimburse the local jurisdiction 50% of the value of the credit. And I don't know if Kevin Canali is here, but MACO supports this bill. And also WMDA, the service station, convenience store, and repair facilities has also issued supportive, favorable testimony. I just want to really quick point to, there's a PowerPoint that's a separate document in your testimony folder, which has some examples of some of these abandoned gas stations. One is in Baltimore City, East Baltimore on Gay Street, which I saw when I was on a committee trip, seeing the good work that Rebuild Metro is doing, addressing the vacant properties. And this abandoned gas station is right in the middle of a neighborhood that they're revitalizing. The other one that I have in that PowerPoint is in Columbia on Stevens Horse Road. There's no infrastructure or gas station left on the property. It's just a big concrete piece of property. Real property records show it vacant as far back as 2012, but community members believe it's been vacant for over 20 years. So a tax credit could allow something like this, instead of sitting vacant, to be something that would be a benefit to the community. So with that, I ask for a favorable report for HB 12. Thank you so much.
Thank you. And Mr. Canali is with us virtually.
Good afternoon, Madam Chair and members of the committee. Kevin Canali here on behalf of the Maryland Association of Counties in support of the bill. I think Delegate Ruth did an excellent job walking through what the bill would do. This is certainly an issue in communities across the state, abandoned gas stations, service stations. And really, you know, when you talk about vacant and abandoned property and redeveloping it, a lot of this equipment is highly specialized, right? They have giant tanks under the ground. This is not your normal just clear the site and redevelop. That this is more than that. And again, you're talking about very specialized equipment that costs a lot of money to try and remove and remediate. So we really appreciate the flexibility in this bill. We appreciate that it's enabling, and it really is designed to allow counties to enact this credit in the way that would best benefit their community. And again, it does help to address vacant and blighted property. And hopefully you can also get some affordable housing from this with mixed use developments, residential developments. So really a great bill, a lot of flexibility here to address a problem. And with that, Madam Chair and members of the committee, we'd ask for a favorable report, and I'm happy to answer any questions.
Thank you. So any questions for Delegate Ruth or Mr. Canali? We'll start with Delegate Hartman.
Thank you, Madam Chair, and thank you, Delegate Ruth, for bringing the bill. Question, you were limiting or restricting dollar stores from taking advantage of this tax credit?
Yes, Delegate.
So in a lot of neighborhoods, I noticed dollar stores are maybe some of the only access some people have because they're close in walking distance. And the dollar stores, I think, are doing a better job of bringing fresh fruits and produce that might be the only means. We talk about food deserts often, so just curious as to why you would make that limitation.
Thank you so much for the question. I can say in my district, there are food deserts, and the community members in those districts definitely do not want more dollar stores. There's already a proliferation of dollar stores. They want good retail establishments. They want fresh food grocery stores where they can really buy the variety of fresh foods that they want. So you know, we really just want to make sure that this is used for what the community really needs and wants.
Okay, the size of some of these lots are kind of prohibitive from a larger store. And I just think you're leaving out some good options for folks that otherwise wouldn't have anything. But thank you for the answer.
Thank you.
Delegate Hornberger.
Thank you, Madam Chair. I love this bill. I'm intimately familiar, having previously had a UST remover's license and done some of these jobs. So two questions. One, at the conclusion of the removal of the tank or abandoned in place, the MDE signs off on the property as being certified as clean. I didn't see anything in the bill language here that says that before that property's transition, that MDE has to sign off.
Thank you for that question, Delegate. That's a really good question. The bill tends to be not have a lot of those specifications because we really are leaving it up to the once we enable this, the counties would then have to pass something in themselves to actually create it. And the bill says that they would be determining the details. However, I believe part of the issue is that sign off has to be done anyway before the property can be used for something else. So, you know,
So if they were to, let's say, attempt to fix the site and never got it into compliance, it would preclude any future use.
Correct.
Okay. And then the second question, so if you'd be open to amendment of saying that, you know, this tax credit can only be issued if there is successful sign off.
Absolutely. If the committee would like to amend that.
And then the second question that I had, many of these properties that are heavily contaminated, if there is a concern that it's going to leach into groundwater, the MDE will require them to install monitoring wells. And these monitoring wells sometimes, in some cases, have to be monitored and tested forever to ensure that contamination doesn't go into adjacent wells. So my second part question is, would this tax credit be able to be utilized for maintenance over time, because the costs are going to be incurred past the sign off from MDE?
Oh, yeah. Thank you for that question. And again, the bill leaves that to the discretion of the counties. It says that the counties can determine the amount and duration of the credit. So if they wanted to enact a credit that would over time allow for that monitoring, that they could do that.
Okay, thanks so much.
Thank you.
Delegate Buckle.
Thank you, Madam Chair. I like Kevin, I've never taken a storage tank out of the ground. I've done some litigation over, they call them lusts, leaking underground storage tanks before. And so this bill, it only applies to commercial properties, right?
Correct.
There's like a fund in Maryland that if you have underground storage tanks on a residential property for heating purposes, that they already pay you to sort of remediate that. When would the credit kick in functionally? Does it only kick in after the property owner has completely removed the underground storage tanks or converted the property? Or is it kick in at the beginning? Because sometimes the costs are, everybody has these formerly small gas stations that usually were not part of a large gas station, ExxonMobil network or whatever, and they've gone out of business. The tanks are usually still in the ground. The pumps are still sitting there, although there's no gas in them. And they're small, they're small areas. The financing for them is really high. Does the property tax credit kick in to sort of provide an upfront incentive to the owner? Or does it only kick in after they've completed the whole, sometimes it's multi-million dollars for a, quarter of an acre property?
I don't know the answer to that. I would have to go back and look into that based on the language of the bill. I believe that, again, that would be up to the counties, but I want to make sure that the bill is not preventing counties from doing something upfront if they want to do that, because you're right, that can be a pretty heavy upfront cost.
Okay, thank you.
Thank you.
If I may, Delegate Buckle, I read the bill as that would be up.
You went on mute.
I'm sorry, Delegate Buckle. As I understand it and read the bill, that would be left up to the full discretion of the county. So they would be able to determine when the credit would kick in. And to Delegate Hornberger's question, I think also be able to determine the duration of the credit and if it could be used for ongoing and recurring costs.
Thank you.
Okay, any further questions? Delegate Griffith.
Thank you, Madam Chair. And I thank Delegate for bringing the bill. Just a quick question. I'm looking at the bill and how'd you come up with this definition of discount store? Where did that come from? Is that a legal term? Is it just?
That was the bill drafter. I don't know where that definition came from. I'm sorry.
Because there's a combination and variety of convenience and consumer shopping goods, and the majority of the items in the inventory price do not exceed $5. So if the majority of the items in the store exceed $5 under this definition, but could you please
Thank you. The intent was to exclude dollar stores.
Yeah.
So sometimes it might be, $2, I guess, in some of the stores, but the intent was to exclude dollar stores, and the drafter came up with that definition as a way of trying to define that.
all right, thank you very much. I appreciate it.
Delegate Miller.
Thank you, Madam Chair. That just prompted some. So Dollar General has the grocery stores now, like they have actual grocery stores. So I didn't know if your definition would prohibit something like that from coming. And this is just a question to think about going forward. It's as you're specifying some definition like that, I don't know where that would fall in them, but I've seen those where they're specifically different than a regular Dollar General.
Well, thank you so much for the question, Delegate. And I believe if it's an actual grocery store, there would be items greater than $5 and for most of the items, and that would not be excluded from these. It doesn't specifically say any particular brand. It's just the amount of the cost of the merchandise.
Okay, any further questions? Okay, seeing none, thank you both. That concludes the testimony on House Bill 12. House Bill 108, Delegate Pastor, welcome.
Good afternoon, Chair Atterbury, Vice Chair Wilkins, and members of the Ways and Means Committee. I am Delegate Cheryl Pastua, and this is about House Bill 108. Yesterday, you heard from two exceptional superintendents, but no matter how good the superintendents are, the truth is that they must have a solid working relationship with their school boards, which set policy and procedures, vote on budgets, spend enormous amount of hours at board and committee meetings, are in schools, at town halls and community settings, at graduations, and so much more. We know that money is not the only barometer for measuring the worth of a job, but it does demonstrate recognition of its importance. Baltimore County's Board of Education, as I speak, is paid less than half the salary of the two systems slightly above it in size, and equal to or less than 7 systems which are much smaller. This bill brings Baltimore County to a respectable and respectful level. It begins to tell our children and parents that we care about them and expect diligence and professional behavior and work for our children. It has been approved by the county executive, unanimously approved by the Baltimore County Delegation Education Committee, and will be voted on tomorrow morning. I appreciate the work of this committee and look forward to a favorable vote. Thank you.
Thank you. Are there any questions from the committee? Okay, seeing none. Thank you very much, Delegate Pasteur.
Thank you.
That concludes the testimony on House Bill 108. Delegate Patterson, House Bill 151.
Thank you. Good afternoon, Madam Chair, Madam Vice Chair, and colleagues of the Ways and Means Committee. For the record, I'm Delegate Edith Patterson. I'm here to introduce House Bill 151, which is a Charles County Board of Education's vacancy procedure. The purpose for the bill is to close on loopholes in terms of timelines, procedures, and overall assurance that there's full transparency when a vacancy occurs with the board. The initial bill was amended at the suggestion of the Charles County Board of Ed from 60 days to 90 days for the vacancy to be filled. We have no problem with that. Also, the way that the position is announced to the public, there was an amendment. Again, the Board of Education and the delegation are in full agreement. So hence my request is that we have full support from this committee for the approval of House Bill 151.
Thank you. Any questions for Delegate Patterson? Okay, seeing none, thank you very much.
Thank you.
That concludes the testimony on House Bill 151. And House Bill 2 and 86, I do not see Delegate Boyce yet. So let's just take a moment. Little elevator music. I know she does not get reception.
I just want to recognize someone. Madam Chair, if I may, and since we're taking a break, Nicole from my district is here visiting. Hello, welcome to the Ways and Means Committee.
Sorry, we just finished a briefing. I'm so sorry.
Are fine.
I'm
So
sorry, which bill?
catch your breath. We will start with House Bill 2, Delegate Voice.
Oh, thank you so much. And good afternoon, Chair Atterbury, Vice Chair Wilkins, and members of the Ways and Means Committee. For the record, I am Delegate Regina T. Boyce presenting HB 2, Baltimore City, Property Taxes Authority to Set a Special Rate for Vacant and Abandoned Property. HB 2, as you all passed last year, thank you so much, would enable the mayor and city council of Baltimore City to have the authority to set a special property tax rate for properties that lie vacant and abandoned. And these vacant properties are identified by a vacant building notice in Baltimore City. HB 2 ensures the efficient usage of a sacred resource while increasing municipal revenue. As of February 15th, 2022, there are 13,632 vacant privately owned properties. And as of December 2023, more than 20,000 vacant lots and tens of thousands of more homes that are affected because they are next to vacant and abandoned properties. Properties that are privately owned must go through due process before the city can act to demolish those properties or make plans to take ownership and bring them back into productive use. HB 2 will speed this process of land reformation while allowing the government to do more with less, and of course, increased revenue for devaluing land. In Washington, D.C., my birthplace, vacant property tax is at $5 per $100 assessed value, and blighted property is taxed at $10 per $100 assessed value. In 2016, the District of Columbia collected $9.4 million in tax revenue, specifically from vacant property tax. And however, though, it could have been a lot more. In 2017, DC auditor found that the loose Department of Consumer and Regulatory Affairs, their regulations, loose regulations, however, led to $1 million in lost tax revenue from those vacant properties that year. And the city could have been losing out on a significantly more if they had not caught this mistake. Again, however, something that produces a lot of revenue for a jurisdiction. Abandoned properties lead to disconnectedness, preventing what inherently makes cities attractive and productive. Responsible land use is not only conducive to positive economic activity and growth, but is also vitally sustainable in our current environmental climate, making sure that we are incentivizing those who own land that is limited in a city, to act responsibly with their property is crucial to the maintenance of a productive city, and especially my city, Baltimore City, the state city. I continue to thank you for your time and your consideration for the support of HB 2. Thank you so much.
Thank you. Any questions for Delegate Boyce? Okay, seeing none, that concludes the testimony on House Bill 2. We will move to House Bill 86, and you have a number of virtual witnesses, so we will go through whoever's here first and then move to the virtual witnesses.
If there are persons who are part of my panel here, can they come up, Madam Chair? Is that okay?
Can you
I don't know.
name those folks?
I ran in here. I didn't see if there was anyone in here.
So in person.
They're all virtual.
Here first, and then move.
Oh, there's one. If there are persons who are part of my panel. There's no one physically here. I think they're all online.
Okay, so we thought that here would be Laura Stewart, Balashade, Afalobi. Those people aren't here. Okay, and then we have a couple favorable with amendments that were going to be here. Robin Elliott, Liz
Mhm.
Elliott.
Yeah.
Okay, so everybody is online.
Okay. Ready?
Yeah.
Okay. And thank you so much. Good afternoon again, Chair Atterbury, Vice Chair Wilkins, and members of the Ways and Means Committee. For the record, I am Regina T. Boyce, testifying on HB 86, Public and Non-Public Schools, Auto Injectable Epinephrine and Bronchodilator Use Availability Training and Policies. Of course, for historical reference, this bill has been before you in 2020, 2021, 2022, and 2023. Last year, the bill was amended in subcommittee.
Sorry, I'm trying
And
to
I would
do.
like to note, at this time, the bill was slightly misfiled and should only be addressing the bronchodilator as an emergency use tool to Maryland Education Code 7-426, which already includes an EpiPen and already has its own regulations and certainly Narcan use. HB 266 requires each county board of election and authorizes non-public schools to update their policies and requires school nurses and school personnel to complete training before being authorized to administer stalk-albuterol. The bill requires a policy to obtain, administer, and train school personnel to administer bronchodilators to certain students. Also requires the State Department of Education to develop training for the school personnel and identification of respiratory distress in students. According to the Asthma and Allergy Network, 7.6% of Maryland children have been diagnosed with asthma. 56% of children with asthma do not have an asthma plan on file at their school. Nationally, asthma is the leading cause of absenteeism attributed to chronic illness, and it's reported that 19.2% of parents with asthmatic children report that their children miss 1 to 2 days of school because of their asthma. Children are at a greater risk of severe anaphylaxis, especially at school, than in any other setting, as well as having an asthma attack. In the US, asthma is responsible for 10 deaths a day. Given these stats and risks, states are considering stalk-albuterol, rescue inhalers, and policy and guidelines. Just to name a few, currently 16 states, Arizona, Arkansas, California, Georgia, Illinois, Indiana, Iowa, Kentucky, Missouri, New Hampshire, New Mexico, Ohio, Oklahoma, Texas, Utah, and Virginia have stalk-albuterol laws. And 2 states, New York and Nebraska, have stalk-albuterol guidelines. What I've learned about asthma, of course, is that you can't diagnose it without first having an incident or an attack. And unfortunately for some, an initial attack can lead to sudden death. An inhaler, I believe, is an important life-saving tool as much as an EpiPen or Narcan, especially in our schools where most children will have their first asthma attack if they do not know that they have respiratory issues. I thank you. I thank the committee again for your time and consideration of HB 86, and I ask for a favorable report.
Okay, we have a couple folks signed up. I'm just going to call their names that are either favorable or favorable with amendment that are in person. So I'm going to call them now. And if you are here, please come forward. Laura Stewart.
I'm sorry, Madam Chair, my individuals who are panel are on virtually.
So we don't have a panel designated. Can you tell
I'm
me
sorry.
who you want?
It should be Dr. Sadramelli, Alex Casper, and Elaine Paps.
Okay. Okay, we'll get those.
Yes, ma'am. Thank you.
Okay, we will begin with Alex Casper, and everyone will have 2 minutes. We can't hear you.
Just that I'm unmuted.
Okay, we can hear you now.
Okay, great. Good afternoon, Chair Atterbury, Vice Chair Wilkins, and members of the committee. My name is Alex Casper, and I'm the Director of Advocacy for the American Lung Association. We're pleased to support House Bill 86 and thank Delegate Boyce for her advocacy. You have my written testimony, so I will focus on some important points. We're here talking about kids having asthma medications available in schools who are in respiratory distress in an emergency. No different than what the current law says for EpiPen or Narcan. No previous history or diagnosis is required for either of those medications in an emergency. You will hear from my clinical colleagues today that rescue asthma medications, namely albuterol, is a safe medication and the clinical gold standard for asthma care following international and national guidelines, not epinephrine, as you may hear some suggest. My colleagues are specialists who care for pediatric asthma patients and their families day in and day out. They educate families and caregivers every day on the signs and symptoms of asthma. They understand what the standard of care and treatment and management of asthma better than anyone you might hear from. They wouldn't be here in support of this bill if we were proposing something that wasn't the standard of care. You have my written testimony. You have written testimony from these experts: pediatric pulmonologists, allergists, school-based health physicians, nurses, pharmacists, respiratory therapists, and 2 organizations that advocate for people living with asthma and allergies, all supportive of broad respiratory distress. This policy is passed in 18 states. Texas just revisited their legislation to remove diagnosis requirements. You may hear also today that it's hard to tell the difference between allergic reaction and asthma flare. I will defer to my colleagues, the clinical experts who educate families like mine who have children with both food allergy and asthma. I can tell the difference between the two, and honestly, so can my son. I leave you with this thought. This bill is about equity. It's about ensuring that all children who need this medication in an emergency can access it, regardless if they are able to get the right paperwork on file. Thank you.
Thank you. Elaine Papp, for 2 minutes, please. You're muted.
Chairman Atterbury and members of the committee, my name is Elaine Papp. I'm a registered nurse with a master's degree. I advocate for the passage of HB 86. As you may remember from my previous testimony in 2018, I saved a student's life but lost my school nurse job. The student had an asthma flare but no asthma inhaler or doctor's orders on file. She would have been considered undiagnosed, yet her inhaler was locked in the gym teacher's office. Paramedics called, were very delayed in responding. The student lost consciousness and was gasping for air, and I gave her someone else's inhaler by placing it into her open mouth, puffing the albuterol into her airways, and soon she was awake because she had gasped the medication in. My written testimony includes details. Today, I want to address the fear regarding 2 provisions of the HB 86, which some here want to amend. Given an undiagnosed student of respiratory distress, giving them albuterol, and allowing non-medical but trained personnel to give medication when nurse is unavailable. You will hear that including these provisions is harmful. There is fear that the student who has an allergic reaction and needs EpiPen would be given an inhaler instead. However, there's no data showing this to have happened in other states. Please consider all the people and organizations across the U.S. who support the provisions included in this bill, who have passed legislation and have studied it. Allergy Asthma Network, they advocate for children with allergies, food allergies, as well as asthma. The American Lung Association, the American Thoracic Society, and the National Association of School Health Nurses. These organizations studied asthma in school for 2 years, published a policy that includes all the provisions in our bill, and endorsed in writing the ATS Journal in September of 2021. You have a copy of it. The Maryland Pharmacist Association, Dr. Christy Sadramelli, and all the professionals testifying here today from a variety of specialties, 16 other states who have the same legislation as ours. Would these states, professionals, and nationwide organizations support this bill if it was dangerous to children? No, they would not. I urge favorable vote of the committee as it is written. I thank you. I'm available for questions.
Thank you. Dr. Sandriamelli.
Hi, my name is Dr. Christy Sadramelli. I'm a pulmonologist at Johns Hopkins, and I've treated thousands of children with asthma from all over Maryland. As chair of the Pediatric Advocacy Committee for the American Thoracic Society and a co-author on the most recent stock albuterol policy guidelines, I'm considered a national expert in this. I've advised other states as they write their laws, and it's time for Maryland to join them. I ask you to reject any amendments that would have restricted this law to students with a proven asthma diagnosis. Consider other laws you've passed. Neither the Narcan nor EpiPen legislation require a student to prove their diagnosis. The schools are trained in recognizing symptoms. These laws are successes. This law should also not require a child to prove they have asthma to receive albuterol. Many children diagnosed with asthma do not supply their school with documentation of their diagnosis and their albuterol prescription. This law would help these children and their schools. It would also help students who have previously not been diagnosed with asthma. None of the opponents are experts. They've made statements that ignore published data, go against national guidelines, and disregard the good experiences of other states. They do so out of a professed concern for undiagnosed children. But my colleagues and I are specialist and non-specialist pediatricians all over the country, and we disagree. Albuterol is the gold standard for quick relief of asthma symptoms, and EpiPen is the gold standard for quick relief of anaphylaxis. It would be unscientific and irresponsible to intentionally treat children suffering from asthma attacks with EpiPens. EpiPens are not FDA approved for asthma, and no asthma treatment guideline recommends them. About 100 years ago, before albuterol was invented, epinephrine was used to treat asthma, but science has advanced. In 2024, we use albuterol for asthma because it's more effective and has fewer side effects. Please don't structure this law based on a 1920s era approach recommended by non-experts. Please listen to experts. School nurses and staff around the country use these protocols every day and love them. The children of Maryland are relying on you. Please do not amend this bill to create the most restrictive stock albuterol law in the nation. I urge a favorable report for HB 86 as written with no amendments. Thank you.
Thank you. Delegate Boyce, I had just, is a Lynn Gerald or Jennifer Dancer on your panel? You have a lot of people signed up in favor, but. Okay. Okay, so we'll have questions for anyone that was just on that panel and Delegate Boyce, Delegate Plakovich-Carr.
Thank you, Delegate Boyce. Good to see you. I don't think I've noted in the past when we've heard this bill, but my husband's actually an asthmatic, was diagnosed as a kid. And when we've talked about this bill in the past, he said, oh, this is the type of thing that really would have helped me because he's a very forgetful person. I just wanted to get clarification. Early on in your testimony, you said that you didn't intend for the bill to, I guess, touch any of the parts of statute that have to do with epinephrine injection.
That is correct.
Okay,
Absolutely.
I just want to make sure I was clear on your intention there. Thank you.
Any other questions for this panel? Okay, seeing none, thank you. I mean, you're welcome to stay. I'm going to call up the folks that are present because that's our policy. So we are going to do Laura Stewart. If she is here, she's not seemed to be here. Bolashad Afolabi. Okay. Nilesh Kayalanarama. Robin Elliott and Liz Elliott. And whoever would like to go first, and you each have 2 minutes.
Good afternoon, Chair Atterbury, Vice Chair Wilkins, and members of the Ways and Means Committee. Thank you for having me here today to speak on this bill. For the record, I am Dr. Nilesh Kalyanaraman, the Deputy Secretary for Public Health at the Maryland Department of Health. In schools, it's not uncommon for children with asthma to experience barriers to having access to their own bronchodilators. To address this gap, MDH supports a stock bronchodilator program that has clear guidelines in place to ensure that the program is safe for students and is streamlined to ensure that school health nurses and staff can focus on care and minimize administrative burden. For children with a diagnosis of asthma or a history of bronchodilator prescriptions, having a stock bronchodilator available for their use will allow them to get the treatment they need during school. School health nurses and designated staff can administer these stock bronchodilators as they do the prescribed bronchodilators. For children without a diagnosis of asthma who have respiratory symptoms, especially for the first time, whether to administer a bronchodilator or not is a challenging clinical decision, and that's not appropriate for school health staff. These children should be evaluated by a licensed healthcare provider for diagnosis and appropriate treatment. However, in a medical emergency for respiratory distress in a child without a diagnosis of asthma, MDH does support the use of a stock bronchodilator as part of the emergency response that includes 911. MDH could support HB 86 with amendments to remove the requirements for training school personnel and designated volunteers to distinguish between asthma and anaphylaxis or respiratory distress, authorize school nurses and other school health staff designated by the school nurse to administer a stock bronchodilator to students with a diagnosis of asthma or who have without a diagnosis of asthma or who have not been prescribed a bronchodilator only in an emergency, and require reporting and parental notification only when the stock bronchodilator is used, similar to what we do for epinephrine or naloxone, and not when the student's prescribed inhaler is used. MDH respectfully asks the committee to consider MDH's amendments to HB 86. Thank you.
Good afternoon, committee members. I am Elizabeth Elliott, President of the Maryland Association of School Health Nurses, and my mission in that role is to help our state's kids grow into healthy and thriving adults. I've worked as a school nurse since 2009 in Montgomery County, and I'm here in support of House Bill 86 with just a few tweaks that Dr. Kay so capably described. Stock bronchodilators for kids with known respiratory distress or asthma will keep kids in school. And it's also really important to get kids the care they need if there is an incidence of respiratory distress in school and children don't have a diagnosis. The National Association of School Nurses that you heard a little bit about just now does not currently have a position statement on stock bronchodilators. NASN absolutely supports asthma-friendly schools that provide for safe and supportive learning for kids, but there is not a position on stock bronchodilators. And in the 18 states that do have stock bronchodilator programs, some actually require a prescription and parental permission, and many are permissive rather than mandatory for districts. And the other thing I just want to say is that this is a long time coming. We school nurses really do need another tool in our toolkit to help provide care for students with asthma, respiratory distress, and say their inhaler is at the gym bag at home. And we look forward to working with MSDE, with MDH and other stakeholders to make this happen. Thank you so much for your time.
Hey, good afternoon. I am Robin Elliott, no relation to Liz that we know of. And I represent the Maryland Nurses Association, as many of you know. We too are in support of the bill with amendments. We were very favorable on the bill that passed the House last year. Thank you very much for all that work. We really think stock bronchodilators, as Liz said, are an important tool in the school nurses toolbox. We've been listening, working with the department, and have also heard some of the other advocates, and of course, Delegate Boyce raise other circumstances where stock bronchodilators may be used. We'd be happy to work with the committee to evaluate, in what cases that would be safe for the student, and be happy to work with you on amendments. Thank you.
Thank you. Any questions? Delegate Plakovich-Carr.
I think my questions are mostly for the Deputy Secretary, and I'm sorry, I'm not going to try your last name. As someone who also has a difficult last name, I feel a little bad for wimping out here. Okay. Having looked briefly through Department of Health's testimony, it looks like you all are proposing, you've written out some amendments, which is very helpful. We appreciate that as a committee. Can you just explain a little bit more about what you would envision as constituting an emergency? Because the draft language that the department has shared talks about emergency situations.
Sure. So an emergency delegate would be one where a 911 call would be required, right? If the challenge we have is that it's easy to say when a child is in respiratory distress and can't continue with the day that they need to go for, they need a higher level of care. But how do you distinguish between asthmatic symptoms, right? When it's less severe, when it's mild, that is what licensed healthcare providers do. And I think the challenge that we have is that we want to get those children evaluated. We want them to get the care they need, the prescriptions they need, right? And so that's the distinction that we're making, is that we don't want to substitute being able to see a doctor or nurse practitioner and doing ongoing treatment, which may or may not be the correct treatment. In hindsight, we can always say, oh yes, that was asthma, but this is not hindsight. We need to get the diagnosis correct at the top.
Okay. So like if a student was coming into the nurse's office on a weekly basis, on a daily basis with asthmatic symptoms, if they were not in acute distress, would you say that constitutes an emergency situation or not?
If they had not been diagnosed at all, right? I think that, so in that setting, if student is coming in, that's a call to the parent. The first time that happens. If the second time that happens, that's a call to the parent. And then that, excuse me, that gets escalated, right? So when you ask, is that an emergency? It's a social emergency at that point, right? That should have been dealt with far before the fourth or fifth call. So that usually does get resolved because the nurses are doing that and school health staff are doing that.
Okay. Within the blueprint for Maryland's future, you know, we're making investments in community schools, more wraparound services, health services. Do you think there are areas there where we might be able to do more, I guess, on that front? Because like we all recognize that there are kids with underlying health conditions who have not been diagnosed, who have not seen a doctor because of family circumstances, and we all want to get those kids the medical treatment that they need. Do you think there's more we might be able to do on that front in addition to having a stock inhaler program at schools?
So this is exactly where school-based health centers come into play, right? So school-based health centers are able to provide a full range of healthcare needs, including providing diagnosis and treatment. And so as we see that expansion, and I think as you know, about a year and a half ago, the program moved from MSDE to MDH, we're actively soliciting schools and districts to increase the school-based health center presence in their communities. So this is exactly where this would tie in.
Okay, thank you. And last question, Madam Chair. Very appreciative that Department of Health and MSDE this summer released their new guidelines on treating students who have severe food allergies in the school system, and those new guidelines are very helpful. What do you envision, you know, under this bill, under the amendments that Department of Health is putting forward for a student who has both an, let's say, either an asthma diagnosis or perhaps is suspected of having asthma, as well as say a severe allergy to food or bee stings or something else, what that would look like, how that would play out if they're in respiratory distress and coming to the nurse's office? What does that look like in terms of care for that child?
So if assuming the question is that we don't know that the child has asthma in this situation, right? And epinephrine is going to help. It's not the correct medicine, right? If you know it's an asthmatic, if it's asthma or an asthma symptom, but epinephrine will help. And also that's a child, if they're in true distress, needs to, once again, that's a 911 or go into urgent care. So there are protocols to be able to distinguish what is an anaphylaxis symptom, right? And for what to, as we envision here, what to do in respiratory distress in undiagnosed children.
Okay, thank you.
Delegate Henson.
Thank you, Madam Chair. My good distinguished subcommittee chairwoman did ask the question that I was planning to ask, but I would like to give a shout out to Dr. K, who did serve as our health director in Anne Arundel County and guided us through the COVID pandemic. So we came to rely on your advice, and it's certainly good to have your opinion on this bill. Thank you.
Thank you.
Thank you.
Delegate Wells.
Thank you, Madam Chair. So I just wanted to, I guess, clarify, or if you could provide some guidance on when it comes to administering, if there is no nurse or medical professional in the school and there's a non-diagnosis, then who would administer in that scenario?
So, Delegate Wells, so if I understand it, this is for somebody who doesn't
like, I'm not diagnosed with asthma.
Okay.
Right? So someone like myself has an episode as a child, you know, on school campus, there's no nurse or medical professional there. What would the response, what would be the, I guess, response from MDH about how we should respond to that scenario?
Well, right now that's the case, right? And so right now what happens is that depending on how that child is doing, that's a call to the parent, or if they have to call 911, that's what's going to happen. But I think our concern here is that treating with a medication that you don't know is actually appropriate for that child is not the right treatment, right? That's a child who actually needs to be evaluated and diagnosed properly and treated properly.
Got it. So if I'm having like a severe episode, we'd want to wait for the ambulance to come. I just want to make sure I'm clear. We would want to, it is the agency's opinion that we would want to wait for medical professional to arrive, whether it be in time or not. That's versus someone just making a call. Hopefully it is the best call, which I think we've heard some scenarios where it has been the case, but I understand things happen. But you're saying that in that scenario, you would rather that we wait for the paramedics to show up and then that we would respond based off of their call.
Which is what we do now, yes, right? Which is what we do now. And that response is typically timely and is also those personnel are able to administer the right medications and also monitor and evaluate and iterate.
If there was a scenario where there was not a timely response, then how conceivably, how should someone respond in that scenario?
So I'll defer then. I get the
I can just give you the perspective of the school nurse with boots on the ground. Right now in the state of Maryland, we have stock epinephrine, and part of the protocol for administering stock epinephrine in the case of an unknown anaphylactic episode is severe respiratory distress. Sometimes you don't know. And so we have stock epinephrine in the toolkit, and absolutely in an unknown case that would be relied on. And that is part of the training that happens right now. School nurses do train backup school staff in case there's no one there from the health room on that protocol and how to give that stock epinephrine. And again, I don't know the details of this because it hasn't been determined, but maybe there might be an opportunity to incorporate stock bronchodilators, but that's just a maybe. And in the case when you don't know, it's safer to give the epi first. That is very clear. In all of the literature from the national organizations, give epi first, and then perhaps we might also give the stock bronchodilator. The most important thing is 911. I absolutely agree. We have to get the child to the hospital.
Okay, thank you.
Delegate Attar and then Delegate Feldmark.
Thank you, Madam Chair. I guess that Delegate Wells' question, I have some follow-up now because of it. So my son has both, he's asthmatic and he has a bunch of allergies. We have an EpiPen. Isn't an inhaler less invasive? And I guess my follow-up question to that would be, what are the concerns and what are your concerns specifically with giving someone an inhaler if they are not asthmatic?
So let me answer the second question first, Delegate. So every medication we give has risks. When you give it for the right indication, it's worth it, right? And so we don't ask the question of what's the harm of giving a medication. The question we ask is what's the right medication to give in this moment? And that's true of every condition. So to address the first part of your question, if for any child who's got a diagnosis of asthma at any time, we're not talking about having an asthma action plan or anything. You have a diagnosis at some point or had a prescription at some point, the stock bronchodilator is there to be used, right? This is to be as permissive as possible. But the challenge with providing a medication when you don't know what you're actually treating, you're taking a guess, is that that's what healthcare providers are meant to do, make assessments, make decisions, and then follow up to make sure those are the right decisions. And so delegating that to non-professionals to say, well, what's the harm is really not how we provide care. We want to expand the reach of it, but it can't be what's the harm. That's not the standard we use.
I understand that that's not the standard, but we're talking about a child is in distress. And I know when my child, if there's ever a time that he does not have his inhaler, I am paranoid. I'd make sure he gets it, because a child who is having an asthma attack, they are in distress at that time. So I guess my question would be, you know what? I think I just disagree, and I think I'll leave it at that.
If I may answer that question, though, the first part of that, I agree with you. We want the child with an asthma attack to get the treatment that they need. What I think we're trying to say is that asthma attacks are essentially determined, right? That's a diagnosis that's being made. If you have a child, you have no idea what their history is. If they don't know that they have asthma, you have to actually know that that's an asthma attack, right? And that we can determine that after the fact, but who's making that distinction at that time is really what we're trying to get at, right? And that's where a 911 response or even epinephrine in that case is perfectly appropriate and is available. So it's not that we're saying there's no treatment we're going to stand around. That is not what we are saying.
Thank you.
Yeah, and if I might add from the school nurse perspective, it's the issue when we don't know. If a child has a known absolutely stock bronchodilator. If a child we don't know what's going on. If a child shows up in the health room and they're in severe distress, I don't know what the issue is. I could give potentially a stock bronchodilator. However, the problem is it may well be anaphylaxis, in which case I have delayed life-saving epinephrine, which is immediately indicated and life-saving in the face of severe allergic reaction or anaphylaxis. It's the unknown case that is really the conundrum. I would much rather give epinephrine and send the child to the hospital and have EMS and the emergency room evaluate further than give a child who we don't know what's going on an inhaler and I got it wrong. And in fact, it was anaphylaxis and the child needed epinephrine. So that's the issue. It's not the inhaler, it's the not giving the epinephrine for a potential anaphylaxis. That's the issue, just for unknown kids.
And would it hurt to give them both?
No, absolutely not. We could, absolutely. We could give them both and they still would need to be sent 911, definitely.
I guess I just have to follow up with that. What would be the harm if you first give the inhaler, many kids immediately react to that? Then you don't have to inject them now with something that's more invasive and they now have to go to the hospital. So what's the harm with giving the inhaler first, see if they're breathing fine, at the same time call 911 and they can then determine, do they need to go to the hospital? If it doesn't work, then immediately give the EpiPen.
Well, that is the amendment we proposed, is to provide bronchodilator as part of an emergency response.
But you're saying an emergency response. An emergency can be a child is having trouble breathing. How? Okay,
Oh, I think we're agreeing actually, but
I hope so. Thank you.
Delegate Feldmark.
Thank you, Madam Chair. I really am just trying to clarify because I may have misunderstood in multiple occasions, but I think I heard two contradictory answers. So I just want to make sure I understand. Because in the proposed amendment, I thought I understood the proposed amendment to be that for a student without a diagnosis of asthma, that a stock bronchodilator only be used in the case of an emergency. Is that correct?
correct.
Okay. So I think maybe I misunderstood in Delegate Wells' question. You're in an emergency, you're not suggesting that someone call 911 and wait. You're saying 911 and it's okay to administer the stock bronchodilator.
That is correct.
Correct?
That is correct.
Okay. And is everyone up there in agreement with that?
Absolutely. Yes.
Okay.
Yes. Yes. And then the other thing that goes along with that is if you have a child and you don't know what's happening, they need epinephrine as well. The Asthma and Allergy Foundation is very clear in the cases of unknown and you don't know what it is because the symptoms can overlap quite a bit.
Okay.
The safest course of action is epinephrine and then immediately the stock bronchodilator. Medically, it works better because the epinephrine transiently for a few minutes does open up someone's airways so that the medicine in the stock bronchodilator can work better. And in a true urgent situation, breathing is really important. And so that's the main reason to administer the epinephrine first and then the inhaler. And then I've asked someone else to call 911 all at the same time.
Okay. Okay. And so then the only undiagnosed scenario where you don't believe it would be appropriate to use a stock bronchodilator is when a student is having trouble breathing, but not in severe enough of distress to call 911. Is that accurate?
Correct, but that would also then trigger a call to parent or guardian to assess, right?
Right.
It's not the end of the road, it's
Right.
just a different path.
Okay. Thank you. Thank you, Madam Chair.
Any further questions? Okay, thank you very much for being here. We have some folks that have joined us virtually. Lynn, Gerald, Jennifer Dancer, Lillian Mendelson. Okay, Dr. Gerald, you will have 2 minutes. Thank you.
Thank you, Madam Chair. I'm Dr. Lynn Gerald, Assistant Vice Chancellor for Population Health and Professor of Medicine at the University of Illinois, Chicago. I was the senior author of the National Stock Albuterol Policy Guidelines and the primary advocate for the stock inhaler law passed in Arizona in 2017. I have also advised groups from 10 other states on their legislation. I'm very concerned about the amendments that I'm hearing today, and I urge you to follow the national guidelines in crafting your legislation. What the nurses who testified before me said is not true. The National Association of School Nurses signed on to these guidelines. It is their national document. The guidelines were also approved by the American Thoracic Society, the American Lung Association, and the Allergy and Asthma Network. The two most important components of guideline concordant legislation are that albuterol can be administered by any trained school staff, not just school nurses, because many schools don't have a school nurse available, and also that albuterol should be administered to any child in respiratory distress, whether they have a previous diagnosis of asthma or not. Many children experience their first exacerbation at school, so may not have a diagnosis of asthma. And even if a child does have a diagnosis, requiring school staff to verify a diagnosis or a prescription for albuterol wastes valuable time. Albuterol is the preferred medication for respiratory distress, not epinephrine, especially when a child does not have a diagnosis. Currently, only 2 of the 18 states with stock inhaler legislation have a restriction to give albuterol only to children with a previous diagnosis. And Maryland is the only state where this issue of epi is being raised. My research indicates that stock inhaler programs can reduce 911 calls for respiratory distress by 20% and EMS transports by 40%. Furthermore, all research indicates that 80% of children who are given the medication are able to go back to class. Stock inhaler programs have been the most impactful health intervention for school children that I have seen in my 30-year career. I respectfully disagree with the previous testimony. The National Association of School Nurses definitely have signed on to this document, and I'm happy to share more experiences if asked. Thank you for the opportunity.
Thank you. Next, we will have Dr. Dancer for 2 minutes, please.
Hi, good afternoon. My name is Dr. Jennifer Dancer. I am a pediatric allergist at Johns Hopkins, and I care for children with both asthma and food allergies. I am testifying today in support of House Bill 86. Both asthma and food allergies are conditions that affect millions of children. In the event of an emergency, access to emergency medication saves lives. And in 2012, Maryland led the way to making schools safer for kids with food allergies by requiring schools to stock epinephrine. A key part of that bill was that it was not restricted to those with a prior allergy diagnosis. It's now time for Maryland to join the 18 other states who have already passed stock albuterol laws. Asthma attacks can occur suddenly. The first-line therapy is albuterol. Albuterol is safe, easy to administer, and effective. It provides quick relief of symptoms and can allow a child to return to the classroom and avoid being sent home or to the hospital. I urge you to reject any amendments that narrow the policy to students with a known asthma diagnosis. Lack of school documentation for asthma is not the same as lack of an asthma diagnosis and can be related to healthcare inequities. Plus, asthma symptoms can present for the first time when a child is at school. And some opponents of this bill have argued that stock albuterol would be bad for kids with known food allergies. As an expert, let me clearly state that this is not true. Children with food allergies should have a food allergy action plan at school. And these children, epinephrine is first line for respiratory symptoms, and this bill does not change that. Plus, children with food allergy are almost 4 times more likely to develop asthma. They are also at risk to have wheezing during a reaction, even without a prior diagnosis of asthma. Therefore, adding stock albuterol would ensure that they have access to a second emergency medication if needed. Finally, this bill ensures additional training for school personnel in recognition of both anaphylaxis and asthma symptoms. In short, this bill would be a win for children with food allergy. So I urge you to support the bill and reject any amendments that would restrict this law.
Thank you. Next, Lily Mendelson, please, for 2 minutes.
Good afternoon, committee members. Thank you for the opportunity to testify today. I am testifying as a citizen of Maryland, as a person with asthma, and as a school nurse who has been working in a Baltimore City elementary middle school with a population of about 1,400 students and 200 staff for the past 6 school years. This school year, about 25% of my school population has a reported asthma diagnosis. That's higher than the national prevalence as well as the state and even local prevalence of pediatric asthma. Almost daily, students come to my health suite reporting difficulty breathing, and they don't have orders for albuterol. Fortunately, my school is lucky enough to have a school-based health center, which was discussed previously. So in an urgent or emergent situation, which I think there is a difference between, we have a medical provider on site who can prescribe and administer albuterol if it's needed. We do need consent of the student's family to do that. Unfortunately, this setup is atypical. Most schools in my district don't even have a full-time nurse. They have a school health aide, let alone a medical provider. The sight and sound of a child struggling to breathe is not something I'm easily able to get out of my head. Many times I'm unable to reach a family member. A lot of them are at work with their phones off. So I have to sit next to a child who can't breathe, try my best to comfort them, provide non-pharmacological interventions, and weigh the risks and benefits of activating EMS without even a family member knowing versus waiting for somebody to call me back. This continues until either the student's condition worsens enough that I don't have a choice to call 911 or their breathing issues resolve without medication. Access to albuterol would provide me with a way to safely and legally help students who are experiencing difficulty breathing. For example, despite my best efforts, our health office has updated paperwork for 90 of the over 300 kids with an asthma diagnosis. That means I can only give albuterol to a third of the students with diagnosed asthma. There are 2/3 of the kids in this building who I cannot do anything for if they have an asthma attack. I've been a pediatric nurse for 10 years. Last year, I gave 5 EpiPens for anaphylaxis and hundreds of doses of albuterol. I know the difference. And it's kind of insulting to hear that I might be confused by that rather than take away something that would really be able to help. Thank you for your time, and I welcome any questions about asthma or school nursing.
Thank you. Are there any questions for anyone? Okay, thank you all for being here. Next, Ann Goldsboro, Chris Martinez, Karen Babak, and Mary Elizabeth Bollinger. Okay, Mr. Martinez, you can begin. You have 2 minutes.
Thank you, Madam Chairwoman. My name is Chris Martinez. I'm the Executive Director for the Asthma and Allergy Foundation Mid-States chapter. So I'm located in St. Louis, Missouri, not to be mistaken with our national office in DC. Although I would note the recent letter on January 23rd that our national office submitted in support of HB 86. I'm pleased to be here today because our organization has been enthusiastic about this issue for quite some time. In 2012, our organization was critical in helping the state of Missouri become the very first state in the country to pass stock albuterol legislation. And on the heels of that legislation, we launched a program called Rescue. Rescue provides stock albuterol support, medication, education, equipment, and training to schools in particular to remove that administrative burden. And in 2022, we were able to work with the states of Illinois and Missouri to get that funded at the budget level. So we now have the opportunity to provide that program to over 5,300 public schools across those 2 states, to our knowledge, making that the largest school-based asthma intervention in the country. And we know that those states were extremely interested in the health of all of their children in their school systems, particularly those with or who would be eventually diagnosed with asthma. But it's also true that they were interested in the cost savings. Rescue has found that with the sole use of albuterol, 90% of the time, children go right back to class. And that means that they don't have to get in an ambulance and go to an emergency department for outpatient services. And that reduces the tax burden on the state and its taxpayers. And I just want to close quickly. I was speaking today with the national office, in particular, Melanie Carver, who is our chief mission officer. And she says this about some of the topics today relative to what AFA has said about EPI. This is a misinterpretation of Dr. James, and that there are 2 places where EPI can be used. One, it is a last resort after other asthma-appropriate medications have been used and did not provide relief. Or 2, if it is unclear if the patient is experiencing difficulty breathing from an asthma attack or from anaphylaxis. I thank you for your time. I'm really happy to field any questions.
Thank you. Next, Karen Babak for 2 minutes, please.
Hello, thank you, Chair Atterbury and the committee for allowing me to speak today. You have my written testimony, and so I'm just going to touch on a few things. I am a respiratory therapy manager for our pediatrics division here in Maryland, and I have been a therapist for 22 years this spring, and I have seen a lot of things. I've never had an incident that has resulted in harm or death of a patient in regards to albuterol. What I can say is I've given plenty of albuterol to patients who did not need it, including those without an asthmatic diagnosis, as well as given to my own child who does not have asthma. The potential benefit in those moments outweighed the possible side effects. I also want to highlight that albuterol does not mask other conditions besides asthma. For example, if someone was experiencing shortness of breath due to pneumonia, if they got albuterol, it would not reverse or significantly reduce symptoms unless they also happen to have asthma. There are other medications that exist for asthma, including preventative medications and even others that can offer rapid relief, but albuterol is the gold standard. It is the most effective first line of therapy. It is always immediately indicated as well, because with some kids, their first asthma attack will be their last. And I have experienced that as a provider, and we've seen it in the community as well, from an outpatient perspective. And so just like giving the EpiPen for food allergies in an emergency, it works right away. Giving albuterol does drastically change that trajectory. And I've heard personally in multiple instances witness this. Our emergency room often struggles with our asthmatic population in this area. So as a mother of a school-age child, I want my child's school and other schools they need to help my child and others in the community during an asthma emergency. I am in support of this bill. Thank you.
Thank you. Mary Bollinger for 2 minutes, please.
Good afternoon, Madam Chair, as well as the members of the committee. I'm Dr. Mary Beth Bollinger. I'm a professor of pediatrics at the University of Maryland School of Medicine, board certified allergist. I'm the medical director of the University of Maryland Breathmobile program, which has been providing free specialty care at Baltimore City Schools since 2002. I'm here to support House Bill 86 to include provision of albuterol in schools for children with or without an asthma diagnosis. I've cared for thousands of children with asthma and food allergy from all over the state over my nearly 30-year career. I was also actually part of the multidisciplinary team chaired by Dr. Cheryl DePinto from DHMH that developed a plan for treatment of anaphylaxis with stock epinephrine in children that was codified to law in 2012. Therefore, I can really provide significant insight and expertise in addressing the specifics of this bill, particularly as it relates to evaluation of children presenting with respiratory symptoms with and without an official asthma diagnosis. This is the exact situation when the protocol that I helped to develop for anaphylaxis was designed to include students with and without a food allergy diagnosis presenting with symptoms of a severe allergic reaction. Asthma and food allergy are coexistent in many of my patients, particularly in the patients seen in our allergy practice. Our patients and families are provided education and training in lay terms on how to evaluate their child with respiratory symptoms appropriately with albuterol when the child is having symptoms without a known or suspected exposure to an ingested food allergen. And they would treat that child with albuterol. For example, if they came in from playing outside, exercise symptoms, had a cold, they're told to give albuterol. If there's any question that they had a known or suspected exposure to a food allergen, they're instructed to give intramuscular epinephrine and to notify EMS. This is the exact thing that we're trying to say with the school nurses. I encourage you to support this bill as written and provide essential medical treatment in all schools for over 90,000 children with asthma and likely thousands more with undiagnosed asthma. Thank you for your opportunity. I'll answer any questions.
Thank you. Are there any questions from the committee? Okay, seeing none, thank you very much. I will call Ann Goldsboro again if she is with us virtually, and the last person is Sarah Choi. Okay, you can, whenever you're ready, you have 2 minutes.
I can go first, Ann. That's okay. Yeah. Cool. Good afternoon, Chair Atterbury and members of this committee. My name is Sarah Choi, and I am a pediatric clinical pharmacist at the Johns Hopkins Pediatric Emergency Department. I am testifying today to the safety and efficacy of albuterol inhalers. In our ER, when a child presents with difficulty breathing, wheezing, and respiratory distress, and the concern is an asthma exacerbation, albuterol is administered as the first-line medication, even for patients without a diagnosis of asthma yet. With albuterol being the standard of care, multiple doses are provided, and after reassessment, additional medication, therapies including ipratropium, steroids, and magnesium are provided if necessary. If the patient is still in acute respiratory distress despite these second-line medications, an EpiPen may potentially be an option along with a few alternative medications such as ketamine and terbutaline to help open up the airway. Even with these additional medications on board, albuterol is continuously administered throughout the entire time. Of note, our Maryland EMS protocol does not list EpiPen as a first-line option for asthma, but would be administered if albuterol works quickly in less than 5 minutes and has minor adverse effects, which include tremor, increased heart rate, and jitteriness. In contrast, epinephrine can cause some significant adverse effects like cardiac arrhythmias, tissue necrosis, and hypertension. There is a reason why albuterol is the standard of care in asthma exacerbations, so why would we want to provide a last-line option as an initial treatment if this occurred in a school setting? Providing albuterol to a child can save a life, but there can be harm in administering epinephrine when it is not required. As someone who is the medication expert, I can attest that albuterol is a safe, effective, and necessary medication for our children to have access to in schools, especially for those who have asthma but may not have the paperwork on file. Thank you for allowing me to testify today.
Thank you, Ms. Goldsboro.
Hello, my name is Ann Goldsboro. I'm a registered nurse, and thank you for allowing me to speak today in support of House Bill 86 without amendments. I'm a registered nurse in the Pediatric Pulmonology Division at Johns Hopkins Hospital. I have many years taking care of school-age asthma patients. I'm also the parent of school-age children with asthma and food allergies. House Bill 86 makes really good sense and should be passed just as it's written. Other states have taken similar measures. At this point, 18 states already allow bronchodilators, these asthma rescue medications, to be kept in school as stock meds for breathing emergencies like asthma attacks. As others have already attested, albuterol is really safe. It's also definitely the first-line treatment, not epi. This morning, I spent my morning educating families about exactly how to recognize asthma attacks and how to give these medications. These are things that can be taught to people. It's easy to use. It's an inhaler. It's not an injectable. This is a great plan to have this in school. Approximately 10% of school-age children have asthma. The rates are higher for minority children. They're higher for low-income children. Asthma attacks can be life-threatening. This bill will help with the inequities in health in our state. This will save lives and help protect Maryland's children. Please, please, House Bill 86 without amendment is a great idea. I'm confident that keeping stock albuterol on hand in schools is really good public policy and would benefit the children of Maryland.
Thank you. Are there any questions? Okay, seeing none, thank you both very much for being here today. And that concludes the testimony on House Bill 86, and that concludes the committee's hearings for today.